Welcome back to the second part of our NHS West Yorkshire meeting here in Leeds today. This is our quarterly meeting taking place in December. And a welcome to you. There are people round the table representing health and care across our 5 places and 10 provider trusts in West Yorkshire. We're now moving on to item 15 of our board meeting, and for anyone watching in the room or online, all the documents for our board meeting are available online, and you just need to click on to item 15 if you're following along. So we're going to look at our board assurance framework, and this is a document that looks at the risks and mitigations in terms of delivering our strategic plan over a number of years. So this is very much about medium to long term planning and delivery, and I'm going to hand over to Laura, who's going to give us an update. Laura, would you introduce yourself?
Thank you. Yes. My name's Laura Ellis and I'm the ICB's Director of Corporate Affairs. So there are 2 elements to today's report on the Board Assurance Framework, or BAF as we refer to it. The first is that it sets out the most recent review of our West Yorkshire level risks and the next steps for review of the place level risks. It then maps each of those against today's agenda items to make sure that we're paying particular attention as a board to those risks for which we act as the lead. The report draws attention to a number of changes to our framework. The ones I just want to draw to your attention are that we do now have a new risk on there in relation to the potential risk of emergence of a pandemic. Colleagues will probably recall that that had originally been on our risk register and we agreed that we were going to move it over to the BAF. We've also closed the risk that was felt to be a duplication, and the details of that are set out within the report. Board members will recall that we spent quite some time in development mode in October, and this has really helped to inform the latest review of the BAF. And one of the areas that we talked about in October was around risk appetite. And again, just want to draw to your attention that we are proposing a change to the risk appetite for 2.1 relating to workforce. We bring the BAF for assurance to the board. You can take some of that assurance through the fact that it's been to committees en route, so it's been to our Finance, Investment and Performance Committee, Quality Committee, Transformation Committee, and the process we have followed has been to Audit Committee for assurance. So the board's been asked today to review the updated board assurance framework, note the next steps for the place review, and to hopefully keep in mind our board assurance framework as we go through our discussions on the rest of the agenda. Thank you.
Great. Thank you, Laura. And there is a request throughout all our committee work, whether that's a West Yorkshire committee such as Audit, Finance, Quality, and through our place committees, our 5 place committees, to take our board assurance framework and those risks and have the oversight and mitigation of those. Does anyone would like to comment at all on the board assurance framework? Jane, would you introduce yourself? Thank you.
Yeah, thanks, Cathy. I'm Jane Madeley. I'm the chair of the Audit Committee and non-exec member for the board. So I just wanted to comment a little bit, actually, in terms of the work that's been done in terms of the development. So we see this at the Audit Committee because we have oversight for sort of governance, risk management, and I think this report, the refresh of the situation with the different risks and how we're mitigating against those, and the mapping against the agenda for today is really helpful, and I think it's really pleasing to see that so many of the strategic risks are featuring under various headings in terms of the agenda. When we reviewed it at Audit Committee, I was kind of struck that there's quite a few risks that are sort of held at the board level, but covered then through the place committees as well. And I guess I would really encourage the places as they do the refresh of their positioning in terms of the strategic risks, that they consider, sort of look at it against their agendas as well. So I think, well, I don't know whether we had an agenda and then we look to see how it maps against the strategic risk, but I would encourage us to think in designing the agendas to ensure that we're getting a coverage of the risks and a frequency of that, rather than just mapping it after the event. And I think the more that we do that, this will feel, as we've been trying to do over the life of the development of it, sort of a really sort of useful and important tool in terms of how we sort of govern and manage things. So really it's just to compliment Laura and the work that she's been doing with her team on it. And, you know, I see real steps forward in terms of how it's moving forward. So thank you.
Thank you, Jane. AC, would you introduce yourself?
Thanks, Cathy. I'm Ashu Chatterjee, non-exec member and chair for Finance, Investment and Transformation Committees. just sort of extending what Jane observed there and complementing, and we have been using this within the Finance, Investment and Transformation Committees as well, and it's been working really well. And moving ahead, I think, yes, it's a bit of a learning exercise on mapping the BAF onto the agenda items, but the next year's work program is something that we can proactively inform in terms of both ensuring that risks are covered adequately in the work program, but also balanced with opportunities, so that it's a well-balanced work program for both of those committees. So hopefully we can review that at the audit committee in 12 months' time and then provide you the assurance.
Okay, thank you. Laura, would you like to respond?
Thank you, yes, just briefly, and thank you for those comments. So just to assure the board that we do use the board assurance framework in order to draft work plans. They were used this year in order to draft the committee work plans, and I think what we've seen as we've done the mapping proactively each meeting is that you can see that correlates. So we'll absolutely do that again as we go into next year. Just another word of assurance, I guess, around the audit committee have requested an annual risk report to come in, which is going to come into the next committee towards the end of the year, which will help them to give assurance for the annual governance statement. And as part of that, we are going to map the BAF across our entire range of committees and board, just to give that level of assurance and to identify if there are any of the risks that we don't feel we are giving sufficient priority to. Thanks.
Thank you, Laura. And as colleagues remember, we had a board development session in October. Thanks to Audit Yorkshire for coming to facilitate that session, and to Laura for arranging that. I thought it was really helpful point of reflection for us and challenge, a really effective session, which I've briefly mentioned in my chair's report. Just your point, Jane, on making sure that we're mapping things. We have, as you can see in Appendix 2 of the report, mapped out the reports today and which of those board assurance framework strategic risks we've covered. I did want to point out that some of the risks we haven't covered around infrastructure, for example, we have covered in previous meetings, such as in September when we had a presentation on our infrastructure plan. But we haven't, for some time, done any work on work around the risk around workforce and the inability to recruit and retain staff, 2.1. Kate, you came to a meeting last year to talk to us about that. So I think that's something I'd like to take as an action in looking at the plans for next year. And also looking at our response to climate change, something we've done very a few times in terms of oversight through our integrated care partnership as a health and care partnership, but something we haven't done through this board. So I think those are two themes that we need to look at for our March and or our June board meetings, as well as development sessions. Okay. And there's another piece of work in terms of infrastructure, just to say this is me being a bit geeky now, Laura, but risk to infrastructure, we do have a brief mention to looking at aligning infrastructure plans with the combined authority through my chair's report, but we do need to do a lot more work on that, which we briefly referenced earlier. So, but thank you for the work to you, Laura, and the governance team as well. Okay, are there any other comments, questions at all? No? Okay. Thank you for that. The next item on the agenda is my chair's report, item 16. Colleagues, as you know, what we try and reflect in this report is a number of things taking place across our partnership, a number of things happening nationally, a mention of our work in terms of engagement with local people across West Yorkshire, and also any other work in relation to partners or board development. As you know, we have Change NHS that was launched nationally a few weeks ago, and you've got an update there on the ways in which we're using our existing involvement framework in West Yorkshire, as well as ways in which we're reaching further out into communities to hear citizens' voices, to gain their views. And I'm grateful to Nadra Mirza in her new non-exec role with us, which includes the remit of Citizens of Future Generations, to be our champion for that and to be a critical friend to Paul Hemingway and our involvement team on their work on that. You can see there's a lot of virtual learning continuing to happen with chairs and leaders and health and wellbeing board chairs and place committee chairs, which I'm grateful to Ian and his colleague Hayden, who has worked with me on that. I think colleagues around the system find that very helpful. And we've been doing a lot of work on board development and board succession planning for our 10 NHS trusts within the system, and bringing in our colleagues from Lacala as well as for the ICB board. And I was really pleased at the beginning of this month that we did an exchange of practice, not only across West Yorkshire, but also for our colleagues in NHS England, regionally and nationally, which included the current chair of NHS England and a board member of NHS England, to come and learn about the ways in which we are trying to increase the diversity of health and care leadership, and also make the opportunity to become a non-exec director or a chair in the NHS much more accessible and inclusive. Fatima Khanshah, thank you very much for your help on that. And if you haven't seen Fatima's Can You See Me, Can You Hear Me webcast on how to become a non-exec in the NHS, it's one of my top tips if you're watching this and working out how to do that. We have got a number of points in the paper, including on the white paper in Getting Britain Working, and the opportunity for us to be a trailblazer area. Ian, could I just turn to you just to give a very brief update on where we are on that? There's some information in the paper about investment opportunities with the Combined Authority and for the ICB. Ian, would you introduce yourself?
Yes, hi everyone, Ian Holmes, Director of Strategy and Partnerships and Deputy Chief Executive. Yep, so as you said, Cathy, as part of the Get Britain Working white paper, we were announced as one of a small number of trailblazers to work across NHS and local authority partners to trial and implement schemes to reduce economic inactivity and improve participation in work. We've received £20 million for 25-26. 11 of that's coming through the ICB route, and around about 10's coming through the Combined Authority route to develop initiatives for that. It's fairly tight turnaround because it's coming in from April 2025. So we are working rapidly with partners across places, across local authorities to develop that plan, which we're having a first look at tomorrow. The three areas of focus within it, the first one is around prevention and early intervention for people who are at risk of going long-term sick. So that's working on things like mental health, musculoskeletal disease, cardiovascular disease. The second theme is around improving participation and retention within the health and care workforce. So people working in our sector, ensuring that they're fit and able to work. And the third stream that's running through the Combined Authority is around employer liaison and employee support. So it's quite hot off the press, a lot of work happening. The systems come together really well to progress that, and hopefully we'll have a plan for delivery in the coming weeks.
Thank you, and we can then bring that through to our Integrated Care Partnership meeting in January as well. We're bringing together local authority and NHS leaders with the voluntary sector, Combined Authority and Mayor Braben. Thank you, Ian. A couple of other things. Thank you to colleagues who came together for the Community Services Provider Collaborative, where we had a very robust discussion. Brendan, I know you were part of that, and others, on how we make neighbourhood healthcare possible. So I think there's a lot of action and agreement out of that about being pragmatic in the short to the medium term. And also you'll note that we have been undertaking some ICB exchanges, and our next board development session will be with Greater Manchester, NHS Greater Manchester ICB, where we'll be exchanging practice, particularly on neighbourhood healthcare, ways of working between local authorities and the NHS, and the use of business intelligence as well. So thanks to colleagues at Greater Manchester for agreeing to do that, and to Laura and colleagues for arranging that. I think it'd be a really helpful opportunity. And the last point for me is, as you know, the 10-year plan is in development at the moment for the NHS, and I'm absolutely delighted that Rob has been invited by Department of Health and Social Care, supported by NHS England, to be a co-chair of one of the working groups nationally to develop that 10-year plan, which I'm sure he's going to talk about in a moment, which then leads me on to our focus on sessions into 25-26 from April. Very much need to align with the 10-year plan, our own strategic plan, and those three shifts. And I'd welcome any views from colleagues around the table today and into the new year on how we put those themes together to benefit from the knowledge. Does anyone have any questions at all in relation to the report? AC.
Thanks, Cathy. Much appreciated. And just a question really. As part of the Change NHS consultation and feedback, we are collecting a lot of information or eliciting feedback as a system. Some of it will directly go into the portal, I'm assuming. Would we have access to all the feedback that we elicit from our region? Because even if it's not reflected in the response to the plan, it will be beneficial for us to have a review of that and see whether we have action plans or any response to those. And it will be useful to see that probably in one of the future board meetings.
Thank you. I'm going to hand to Ian, who's already nodding.
Yeah, so we're doing the sort of two main ways that people can provide feedback as part of the kind of the Change NHS engagement session. The first one is there's a series of event sessions happening each of the 5 places across West Yorkshire between now and the end of January, and there's a link in the paper which identifies where those are. The second is through the sort of the national portal where people can upload comments directly. I think the principle that you're sort of establishing, AC, is exactly right, which is that we want to use that information to feed into the national consultation, but we also want to use it to support our local plans. I'm not sure whether the material that gets fed up through the national portal is actually accessible by ICB, but certainly the information that we gather from the workshops that we've got across the 5 places will be, and they'll be used as part of our part of our kind of engagement and evidence gathering that will build on the material that we've already got.
Yes, AC.
Thank you. That's really useful. And the context mainly is if organizations and providers within our patch decide to provide a organizational response, it might be useful to request them if they could share it with us as well proactively, if specifically they are not part of one of the engagement events.
I'm looking at my colleague Paul Hemingway, and I'm sure that will be possible. And I think what we'll do is in between, from the next break, we'll check in and we can reply to you rather than having that sat on an action log. So agree with you. Yes, we want to contribute to this national conversation to inform the 10-year plan, but we also have a very well-established involvement framework and ways of working with local people, and we want to benefit from the effort as well. But we'll come back on that one. Thank you, AC. Is there anything else at all? Jane?
Thanks, Cathy. Yeah, I was just coming back to Ian's comments about the Get Britain Working white paper, and it just sparked a couple of ideas. So one thing within that, it talks about obviously business and industry sort of being involved in part of that. If helpful, there may already be connections, but I have a vice chair role with the Confederation of British Industry in the Yorkshire and Humber region. They're obviously very passionate about this as well. So if it's helpful, I'm really happy to make any contacts. I think they'd be keen to participate, if not already involved in that. And the other thing I was thinking about was last year we had the Neurodiversity Summits, and I was just wondering where that's got to and whether there's anything from that would be feeding into this work going forward.
Thank you, Jane. So thank you for that offer, which we know. Ian, is there anything else to respond on?
I'm not sure in terms of the update on the Neurodiversity Summit. That might be James. In terms of the offer to connect us with the Confed of Industry, that would be fantastic. And I'll check with the team whether that connection's been made, but that would be great.
Thank you. Then we'll go to James, then to Nadra. Would you introduce yourself?
Hi, my name is James Thomas. I'm the Medical Director for the ICB. And so it's just responding to the update about the neurodiversity summits that took place. So that's been taken through and was fed back through the Quality Committee in terms of where that is, and was brought back here last time. But to summarise, that summits have taken place, including a lot of stakeholders, people with lived experience as well. And a lot has happened during that time in order to be able to kind of understand where our priorities sit with this there. So that's been taken forward with leadership within our mental health, LD and autism programme. And we are working, and we've also brought that through to the system, had discussion at our system oversight, and helpful comments from our leaders across the system in terms of the direction we'll travel with this. So we are planning to kind of look to bring something back towards the end of this financial year within our system in terms of the direction of travel, because understandably when we did the summits there were lots of priorities, many priorities from different stakeholders. What we wanted to do is make sure that we were delivering what we felt we could and should, but also we were able to support people and support their carers through this process as well.
Thank you. Nadra, do you want to come in? Oh, sorry, Rob, do you want to follow up on that?
Sorry, I just wanted to I just wanted to add something. I think on Jane's question about, because what I heard was, is there anything coming out of that around how we support people who are neurodiverse into work? And one of the really interesting things about the work we've been doing through the additional resources we're going to be given is how do you segment people who are economically inactive into people who really, really want to work and those who can't. And we know that the numbers vary from year to year, but 5-6% of people with a learning disability are in work, despite the fact that a substantial proportion of people with a learning disability want to work. So I think we've been talking about how do we make sure that the programme does allow for those sorts of interventions which will help.
Thank you, Rob. Nadra, would you introduce yourself?
Hello, I'm Nadra Mirza, non-executive member of the ICB, as well as chair of the Quality Committee. I just wanted to add a network to Ian and the Trailblazer, and just wondered if you'd like to consider the networks around higher education in West Yorkshire. We have 14 providers, and most of them are responsible for in some way or other, to develop the curriculum for professions that come into our health and care services. So that I think would be quite a useful connection, and happy to provide that. Thank you.
Thank you, and I'm sure my colleague Kate Sims would be interested in those networks as well. Okay, Kate.
Thank you. I'm Kate Sims. I'm the Director of People. I guess just to, again, add to what Rob said to Jane's conversation, I've had a meeting with the workforce place leads across West Yorkshire. Ian mentioned the 3 strands of work, one of them which is very much about the health and care workforce, both really retaining people in the workforce, and that they're working up, as Ian said, a really detailed project plan. But one of the groups that was particularly identified were our colleagues who are neurodivergent. So there will be more to say, I'm sure, on that in the early part of sort of January, February, but particularly it was a group within the workforce that was identified in the way that Rob just described. So thank you.
And then we want to take some final comments. Hannah, then Fatima. Hannah.
Thanks. It's just on the point around the development of the neighbourhood healthcare model. I suppose just to say it's really important that the voice of people and citizens is at the heart of that. It should be designed around that, not around what works for health and care providers. And we're just doing some work at the moment. We've been working with Ian and Hayden around that anyway, but I think we're keen to really support that work. And I think West Yorkshire Voice might do some engagement around some of the elements of that as well as part of the 10-year plan sort of outreach as well.
Thank you, Hannah. I'm wondering if one of our focus on sessions for the new financial year is on neighbourhood healthcare, and we focus on that together. It's all what we want to shift to. Everyone's in violent agreement. We just need to make it happen, don't we? Thank you for that. Fatima.
It was just to answer the question about the involvement of higher education and business forums in the work that's been led by the amazing Jen Connolly. Part of the steering group has representation of officers within the Combined Authority who work with Chamber of Commerce. I'm not sure whether it's your forum as well, Jane, but I'd put good money on it that they have covered that base, and there's definitely higher education representation as well. So I just thought it was helpful to just answer that question.
Okay, so there's generally a theme of board members around the table. If there is a network that you think should be connected to us being a Trailblazer site, then please talk with Jennifer Connolly in her dual role between the Combined Authority and ourselves, or Ian as well. So thank you for those comments. And for those of you that are members of the Partnership Board, you'll receive an update on the Trailblazer work into the January Partnership Board, and then we will continue to watch this as it's a 12-month delivery project, and we're in the planning stage at the moment. Okay, thank you. I'm going to hand over now to Rob for his Chief Exec's report, which is item 17.
Thank you, Kathy. So people got the report. As ever, it's things change between drafting the paper and today, so I can provide some updates and some points of emphasis. So just to remind people that what we tend to do in the ICB is focus on what's happening now, how are we getting ready for next year, and how do we create a sustainable medium term. And things are happening across all 3 of those timescales at the moment, and that's reflected in the paper. It's helpful, I think, that the government has got 3 main missions on health, and most of the time people talk to the 10-year plan for the NHS, but let's remember there are 2 others. There's the cross-government working on well-being, And we've already heard today in the Health and Equalities session the importance of housing, education, the environment, employment, etc. And we're already seeing with the £20 million of investment in West Yorkshire the benefits of that wider view. And then the third element of the missions is to reform adult social care. So I think seeing all those things in context is good. And you'll note from the paper it's also helpful and, you know, widely reported and a sacrifice for many people in the country that the NHS and local government has been given more resource in the budget. The details around entirely around what the consequences that are for us in terms of planning, etc., are not fully yet understood, and I'll come back to that in a minute. So, if you look at the paper, I start with quality, and I'm unashamedly start with quality, and I think that's something that we here consistently do, and within the elements of quality around, you know, access, experience, and safety outcomes, we always make sure that safety has primacy, but we do start with quality. And it's no surprise to us that nationally the State of Care report from the Care Quality Commission had a lot of challenges in every single sector. That mirrors what Lord Darcy said about the state of care from his perspective. There is always, though, improvement, and I was delighted to see that our colleagues at Bradford Teaching Hospitals Trust received outstanding in their most recent CQC inspection for their neonatal services, given the amount of scrutiny and interest there'd been in those services. So well done to them. So we do start with quality and safety, and I think the government, and I think a lot of the noise that you see in the media and elsewhere is starting to ensure that that's the focus. There are some other things that have happened since last week, though. So yesterday there was a white paper published around devolution, which is of material interest to us as a partnership. And I've got a few notes that I've cribbed here, or somebody, Hayden, I think, thank you, Hayden, has pulled together for me, just so I cover the bases. I think generally for us, it's a good thing. The intention is a good thing, and highly consistent, I think, with how things work here. For other parts of the country, there'll be more disruption. So primarily what the intention in the bill, I think, in the white paper, is to devolve more powers to places through elected mayors, and so that they can cover housing, planning, transport, energy, skills, employment, and so on. Some of the things that our combined authority already does so well, so all the stuff on the economy and transport, etc. The principal aim is to have a strategic authority at a certain level, so ours would be probably at West Yorkshire level, in line with the combined authority, covering every region in England. And working with the mayors ahead of the spending review, trying to get into a position where they understand how quickly people can move towards that and how we get an innovation funding programme up and running to demonstrate the difference that working locally can have. And that there's a requirement on the strategic authorities, the combined authority in our case, to consider health improvement and health inequalities. Now, personally, I think that's good. The government's talked about having the economy in all departments and economic growth and prosperity, and we talk a lot here about the economic value of the £5.5 billion that we spend. So having a quid pro quo of thinking about health and health improvement in transport, energy, skills, etc. is really helpful. One of the things the white paper talks to is that the strategic authority would be the convener of public services, those wider things like local government, fire, police, etc., plus health, and to strengthen the opportunities to do that, to make sure that things were more coterminous. And in West Yorkshire, again, that's not an issue for us. And to strengthen things further, to consider whether the mayor should be on the mayor should be on the ICP, may co-chair the ICP, or may be the chair of the ICP, the Integrated Care Partnership, and should have a role in the appointment of the chair of the ICB. So it seems to me that that with a promised outcomes framework, it all point to things which I think the devil will be in the detail, but general direction of travel is very familiar to the way that we want to work here and often do. And Hayden's also told me that West Yorkshire is mentioned 16 times in the white paper as an example of good practice. So we must be doing something right. So that's come out, and we'll be exercising colleagues in local government. I know that Robin and Victoria and others will be closer to some of the conversations that are happening. So if that's a kind of a paving the way towards the medium term, we know that here and now things are incredibly difficult. And you will have come across a new term that's been coined, I think, by the National Medical Director, which is the quaddemic. So we're in the middle of a quaddemic of 4 different infectious diseases which are having an impact on people and communities and a consequential impact upon our staff and services. So flu, norovirus, RSV and COVID, and an early flu season which is currently in its exponential phase, having a substantial impact upon people. And many of you around the room will be aware of family members or colleagues, or you may even yourself been affected by these issues recently. That means that we are in the middle of winter now. Winter pressures, we know winter pressures all year round, but we know the amplification of the impact of respiratory illness usually takes place about now, but the flu season is early. We've got a paper later on about winter, and we'll talk, I think, about whether our winter plan is being successful or if there's anything else that we need to do. In terms of planning for next year, planning guidance usually comes for Christmas, and we haven't got it yet, have we? We haven't had an early Christmas present, and last year it was closer to Easter, but I think it's going to be closer to Christmas this year. Irrespective of when we get the guidance, we're already working on what do we think we need to get on top of next year to maintain a focus on narrowing inequalities, unwarranted variations in care, eliminating waste and delivering value for money, and delivering an economic and social return on the money that we spend. And of our places and providers are working on that now. The planning guidance is likely to be shorter, more focused, and to try and make sure that we are continuing to work together in the spirit of collaboration. The final thing I'll say is you'll note in the paper reflections of some of the speeches and communications that have happened about our role in the system. And I think this is one of those times where I think we have to coin a phrase, pick up signals from noise. There's been a lot of noise and actually some clear signals. And the clear signals that we hold on to, I think, are about our role as an integrated care board, as a strategic commissioner of services that improve outcomes for people. And I think if you look at the conversation we've had so far today, that's what we've been doing. So Sarah and Culvent and Sarah's presentation around what do we know from health needs assessment, what do we know works, what do we do in co-production terms with our communities, how do we make a difference, who are our partners in delivery. That strategic commissioning point is critical. And the fact that we contract with everyone means we are interested in the performance and mutual accountability of everybody in the system. And what will be clarified is how NHS England intervenes when required, which I think is very, very welcome in our system. And sitting alongside NHS England and our partners, trying to consider where issues arise, how we deal with them collectively. So the arrangements around that will be sharpened up over the next quarter and should go live from the 1st of April. But for us as a board, I think there's a welcome focus on, are you looking at the evidence? Have you got a true partnership? Are you putting people at the centre of things? Are you co-producing? Are you doing the things that commissioning is supposed to be about? Are you using digital and tech to transform care? All of those things I think that we talk about quite a lot. Hopefully that's a helpful update on top of the paper. Thank you.
Thank you very much, Rob. And as you say, we have the devolution white paper that came out yesterday. And another document, particularly of interest to us as an integrated care board, is NHS England's operating model letter that came out on the 13th of November, which is the day after the Secretary of State's speech to NHS Providers Conference. So your point about the signals that are coming through, there's a sort of key pieces of work there. And just your point on talking with local government, and we have 3 representatives from local government here today, so it'd be really welcome to hear your thoughts on the information that's coming out, including the white paper. But we will be meeting with Health and Wellbeing Board chairs as part of our planned programme of engagement on the 9th of January. And we have our next quarterly engagement with Mayor Braben on looking at planning, which will include Trailblazer and responding to the devolution white paper as well. So we can provide updates on that as well. We will talk about the quademic under winter planning, but thank you for outlining that as well, and thank you to all staff in health and care who are responding at this time and over the festive period as well. Does anyone have any comments or questions at all in relation to Rob's Chief Exec's report? Richard, to you first. Would you introduce yourself, Richard?
Yeah, I'm Richard Vautry, I'm a GP and the Primary Medical Services representative on the board. Thanks, Rob, as always, for your detailed report. I think it's really helpful. Just on the quademic, within Leeds, we actually have 5 virus circulating, so because we've also got measles as well. Now, at least 4 of these 5 are you can protect yourself and your family and friends with vaccination. You know, I think we really do as a board need to step up our promotion of vaccination, support for vaccination, give thanks to those who've responded from Public Health and ICB in Leeds to support communities within this area that we're meeting now, to vaccinate those who are not vaccinated and provide more support to them. But I think this is something that we can't take our eye off the ball. And I think we do need to focus on this because measles remains a very serious illness alongside flu and COVID and other infections as well. And just the second point, in your report on paragraph 217, you rightly highlight the concerns around the rise in national living wage and national insurance. And you mention the impact it will have on care homes, hospices and voluntary communities, social enterprise and other organisations. Of course, general practice and pharmacies and others, primary care providers, are included within that. And I hope as a board we will do all we can to encourage government to do what they can to address that national insurance impact, because without that it will have a serious impact on the ability of our primary care services to maintain the services that they're providing to patients, particularly at this time.
Richard, thank you so much. And it was one of my questions as well at some point during the meeting as well about what we can do as health and care leaders through our organisations in terms of promoting vaccination during this winter period. James, do you want to come in as our medical director for the system?
Yeah, no, thank you, Chair. And Richard, thank you for highlighting that, because I completely agree in terms of your point around vaccinations. And the fact that actually whilst quademic and the ability to vaccinate many of those, there's also the measles outbreak. And in terms of what our system has been dealing with, we've been dealing with that as well and responding really well. I do think our approach to vaccinations has to be year long. It's not just about the campaigns, although the campaigns are really, really important to ensure we get people vaccinated for COVID and flu. But also in terms of our approach now, in terms of publicising our vaccines, we are taking an all-age approach to our vaccinations to really kind of push all vaccinations, because we recognise the importance of them, but also in terms of the uptake. There's no doubt it's been challenging, both in terms of our population and our staff as well. It's important to understand that there has been hesitancy, there has been people have been tired of being vaccinated, and many different stories we've heard here as health professionals of why I won't bother this year, and it's important that we counter that, and it's important that as a clinician we support our clinicians and people across our services to counter those discussions, to help support the uptake of vaccinations. And I think that whilst I think it has been challenging, there's no doubt we always want to do better, and we can do better, and we should be doing better. Actually, our health professionals and volunteers across the system have been working really hard in terms of the autumn-winter campaign. I think despite the pressures on our system, our PCNs, our primary care networks have been out there vaccinating there. We've also had a huge surge in terms of our community pharmacists, in terms of being available and offering the vaccine across the autumn and winter campaign there. And I think it's really important to kind of both thank them in terms of the work they're doing. We've still got time, people still got time to get vaccinated. The national campaign finishes last chances on the 19th, so at the end of this week. However, you can still get your vaccines for COVID and flu later past that time as well, but just not through the national booking system there. So there is an awful lot of work to be done there. I think it's important also in terms of where we are in West Yorkshire. 100% of our care homes have been visited across West Yorkshire in this autumn and winter campaign there, and our uptake has been good in terms of they're higher than it was the previous year as well there. Our housebound have been vaccinated as well. Over 80% of our housebound have been vaccinated across West Yorkshire, which again is at a higher rate than before there. As I said, I think across our health and care organisations, there's more work to be done, and I think there are some really good examples where we've had vaccines being there, being able to offer it there and then to our workforce. But there's a lot more to be done there, and it's important how we support our staff to get the message across, to support them to have it, and also to support them to offer it where it's appropriate there. So I can answer further questions, but I'll probably stop there. Thanks, Chair.
Thank you very much. But then also an opportunity, I know we have our Paul Hemingway with us today, who leads on our communications and involvement framework, so we can go back and find out if there are doubling efforts. Richard, your challenge to us as well. But James, thank you very much for sharing that with us. It's really helpful and assuring. We've got other colleagues who want to come in, Bev, then Victoria, then Mel, and then Rob, maybe we just come back to you to sum up. Bev, would you introduce yourself?
Well, thank you, Chair. My name is Bev Geary. I'm Director of Nursing for West Yorkshire ICB. My comments are with my local maternity and neonatal system hat on, of which I am the Senior Responsible Officer and also the Chair of that board. So this is in relation to the Lord Darcy report on the state of the NHS. And in particular point 2.2 around the CQC targeted inspections of maternity units. Just for most of the board will be aware, but we did have an update from our LNMS Director of Midwifery earlier in the year, but we've got 3 of our units that are rated good, 3 that are rated RI. Unfortunately, there's no opportunity to improve on these as yet because the CQC told myself and Dr Thomas in our most recent regional quality committee that they're only inspecting based on risk. So despite a really significant quality improvement programme that has local board, provider board, system LNMS board and regional board oversight for all maternity units. As yet, I don't think there's much opportunity for those ratings to be improved. As I've said, the CQC are only currently inspecting on risk. So that was one point. The other point that Rob has already highlighted under 2.6 was around the Bradford Royal Infirmary neonatal unit and being rated outstanding for their neonatal care. Again, these findings were consistent with the NHSE desktop review that was undertaken some time ago. And in addition, there was a clinical assurance visit that involved system partners and regional partners, and myself and Dr Thomas were involved in that, and again, consistent with those findings. So excellent for the organisation, but for the families of the babies, these really sick babies in that unit, and we will be taking learning from that unit across the system via the LNMS board. I think I'll stop there, and my comments on winter, I'll wait until number 21 on the agenda.
Thank you, Bev. That's really helpful. And as you said, you provided a system oversight report for us in March this year, and very much want to invite you some point next year, possibly summer meeting, to come back and provide an update if you think that's the appropriate time. And that also aligns then with Nadra joining us in her new non-exec role as non-exec maternity safety champion as well. But thank you for that update. We've then got Victoria, then Mel, and would you introduce yourself? It's just very helpful for people watching the meeting. Victoria.
Thank you, Chair. Victoria Eaton, Director of Public Health for Leeds, and here on behalf of all 5 Directors of Public Health across West Yorkshire. It was just to add to Richard and James's comments in relation to health protection, including measles. I just wanted to share with the board that you might be aware that we responded to our increasing challenge around measles cases in LS8 in Leeds at the same time that we were dealing with the Mpox Clade 1 case, which was it was an interesting Thursday morning with 4 incident meetings all happening at the same time. But what I wanted to share is that the level of system working in West Yorkshire has been exceptional in relation to the response and ongoing work around those challenges. I've just picked up an email that as we speak, there's 3 additional community MMR clinics running in LS8 at the moment, and the numbers of people who are coming forward previously unvaccinated is really impressive. So, and that's a collective effort from many NHS colleagues, including primary care at the centre of that, working really closely with public health teams and others locally. So we've got a really good story to tell there around how we are working with kind of real issues as a real system. And again, just to echo James's comment before, that we've now set up the jointly chaired Health Protection Oversight Board, which I think I don't know anywhere else that has one in the country, but I think we've got a lot of interest from the UK Health Security Agency about how this is happening in West Yorkshire very positively. So, just to echo my colleagues' contributions around how we are being incredibly proactive and harnessing the system across West Yorkshire at the moment. So thank you, Chair.
Thanks, Victoria. And then to Mel, and then we'll come back to Rob.
Yeah, thank you, Chair. Melanie Brown, Place Lead for Wakefield District. I know Richard and James brought this to life a moment ago, but I just wanted to give some local flavour in terms of the flu statistics and the impact that has on patient care. We were looking at some recent admissions data for Mid-Yorkshire system, and of the sort of number of people that were admitted into hospital with flu, sadly 48% of those patients hadn't taken up their flu vaccination. So that just gives the sort of reality of all the work that we can have and the impact that Richard was highlighting. If we can do more collectively as an ICS to overcome this flu hesitancy that we're experiencing this year, which seems to be an outlier for us compared to previous years. I know everyone across West Yorkshire works really hard on promoting the flu campaign, but it does feel like this year we've had some significant challenges. So I just wanted to bring that to life. Obviously, locally in the Mid-Yorkshire system, we're looking at what we can do to respond to that, but I just wanted to bring that to life in terms of some recent data we've been looking at.
Thank you, Mel, and that aligns with national messages that are coming from NHS England as well. Thank you. Rob, are there any sort of reflections before we move on?
Only to say, to add my thanks really to Victoria and James, who've overseen the response to the Mpox case that we've had locally. And it was good to get a formal letter from the UK Health Security Agency thanking them and the system for the work that's gone on to manage that in amongst everything else that's been going on. I know we talk about real change happening in real work, but you probably would have wanted to have embedded the board a bit more before you had to start doing some real work. But thank you for the work that you've done on it. It's been exceptional.
Rob, thank you for your report, and we'll wait to hear more from you on a variety of things, including 10-year plan development. And we know we don't have the planning guidances yet, and board members, you'll be, if you don't know directly, we will make sure that you are updated, including non-execs around the table when that arrives from NHS England. Okay, thank you, Rob. We're now going to move on to items 18 and 19. I'm going to take the two together because they should complement each other if it works in terms of risk management and reporting. So what you have is 18A, Integrated Performance Dashboard across the system, including financial performance. You also then have the Corporate Risk Register, and then you have Committee AAA reports that complement that. In addition, you've got an overview of our 10 strategic ambitions, because our role is also not only Commissioner and Convener of Partnership, but it's also making sure we've got oversight of the delivery of our strategic plan. And I've asked for that part of the report also to come to our Integrated Care Partnership meeting in January. So I'm going to invite Lou, Jonathan, and Laura to give us some updates. Then I'd say if anyone has a place committee report that needs, place committee or other committee report that needs updating, then please let me know. And then we can have a discussion about items 18 and 19 together. So we'll go to Lou first, then Jonathan, then Laura. And would you introduce yourself? Because it helps people watching the meeting.
Yes, thank you. So I'm Lou Auger and I'm the Interim Director for Planning and Performance. And the report that I'm bringing provides an update on some of the key performance indicators that the NHS uses to look at our oversight. I'd like to pull out a few by exception, and I'll just take you through them. So in terms of our elective recovery, we've got a plan and we continue to work really hard. The focus that the West Yorkshire Association of Acute Trusts has put on this. Yeah, sorry. Is that better? I can hear it. Yeah. So there is a focus from our West Yorkshire Association of Acute Trusts on elective recovery, but we're not currently achieving plan. We're meant to be not have any over 65-week waiters, people waiting longer than 65 weeks for their procedure by the end of September. Now, this is not unusual. We're not the only ICB in this position, but we are working really hard on this. The report at the moment gives the August position, and at that point we had 980 people waiting over 65 weeks. And we have halved this in November, and this will reduce again. We anticipate we'll have under 200 people waiting in December. So it is coming down, and there's a lot of work going on within the trusts. Often these are cases that are fairly complex cases that need certain circumstances to actually have the operation. So we are really trying very hard to get everybody treated as quickly as possible. There are, however, significant risks that come with the winter pressures we've just been talking about. So they can bring along delayed discharges, high bed occupancy, and this could have an impact on actually treating patients in a timely way. Wyatt continued to work collaboratively across the services to get the patients treated as quickly as possible and are sharing their resources to do so. I was going to come on to winter pressures. I think we'll probably pick up a lot of that in the winter paper. One of the points I was going to make was around vaccination. I think that's been made very well. There is probably over the past 2 weeks been exceptional pressures across all the systems. Winter's really here, and the systems are working really well, very closely together across health and social care in an exceptional way to actually look after people safely. We are seeing the impact of the different viruses that we mentioned, and there is a full winter communications campaign running. We've got Together We Can. It's been shared across the partnership, and we've got various media releases to help the public navigate to the most appropriate care in the right place at the right time, particularly for minor illnesses. Moving through to some of the other metrics, looking at virtual ward, it looks like we're under the target. In October, virtual ward utilisation was not at 80%, it was at 74%. The point I'd like to make here is that actually we're really good at using our virtual wards efficiently. This is not about stacking them out and making sure that we get to 80%. This is about using these virtual spaces and this virtual care for patients in a way that is appropriate. So it's not about how many we've got in. Some of it is about the length of stay that they have within the virtual ward. So what we have seen is the average length of stay has decreased from 5 to 9 days to 1 to 4 days. So people have needed some care, but not for so long. And this has improved their outcomes and their care closer to home. So I just wanted to pull that one out. Also, we've had improvement in talking therapies, where performance has improved since the previous quarter, and we're consistently above the 48% target. We've been putting in some very positive actions around top-up training for therapists, meeting with comparator services to learn from best practice, etc. So we'll continue with that. And in terms of children and young people services, we've talked about this metric before, and what we've said is, whilst we're over our plan and we're doing really well, it actually doesn't give a true reflection of the pressures and challenges within the children and young people's services. So we have now started to look at a number of sub-metrics so that we can actually look at the service in more detail and see what further work we need to do. And within that, we're also trying to look at the health inequalities and utilisation of the wider services through those metrics. If I may, Jonathan, I'll move on to the 10 ambitions before you do the finance report. So this report now contains, as we have every 6 months, an update on the 10 ambitions. But what's different about this report is that we've actually moved it along, because the 5 years that we set the first metrics for have now expired. So as part of the publishing of the Joint Forward Plan in 2024, we updated the 10 strategic ambitions, and we looked at the way in which our measures were being used, and also looked at some sub-measures so that we can actually see what improvement we're making. There's been an in-depth review of the existing measures and the metrics in conjunction with our programme leads and subject matter experts. For each ambition, we've included system outcome measures alongside process metrics, which we feel then that we can directly influence through the work of the ICB. Some of the visualisations, you'll see there's gaps, so we continue to improve the different metrics as we build them, and the board is asked to note that the work continues, and in some cases there's placeholders for future visualisations. We've included in the measures and metrics some of the health inequalities data wherever it's available, and we've also endeavoured to understand the financial costs of health inequalities, which was requested by the System Oversight and Assurance Group when it last met. And the first example of this can be seen in Ambition 3, which is children living in households with the lowest income, where we've calculated the cost of additional admissions for the most deprived quintile compared to the least. So thank you. That's all I wanted to cover on those two parts. Jonathan, the finance section for you.
Okay, thanks, Lou. So this is just a brief update on the financial position to the end of October, so that's month 7. Colleagues will recall that we started the year with a £50 million planned system deficit. That reduced to a break-even position following receipt from NHS England of some non-recurrent cashback deficit support, which in effect takes our plan to break even for the year. So in terms of where we were at the end of month 7, we returned a deficit of £48 million in terms of our year-to-date position, and that was against a plan of a £25 million deficit. So we were £23 million short of our plan, and there were a variety of reasons behind that, which are detailed in the report that you got in front of you. We are, as a system and as individual organisations, continuing to forecast delivering our plan by year end, although clearly that carries some risk at this point of the year. Because what you can see, for colleagues that are following this sort of the pack on page 566, is that we've got 4 trusts specifically, Airedale, Foundation Trust, Bradford Teaching, Leeds Teaching and Mid Yorkshire Teaching, who all have deficit positions as at month 7. And those 4 will either need to hold that position for the rest of the year, so in effect their monthly position cannot deteriorate for the next 5 months of the year, or indeed improve their positions across the 5 months of the year to get back to plan. What that means is that we are working very closely alongside NHS England with those 4 trusts specifically to understand what their financial recovery plans look like, what their risks look like, what their mitigations look like. So, as expected, whilst at the start of the year we signed off plans that were deliverable and credible, we always knew this year was going to be challenging financially. We had some fairly stretching plans, and we can see that in the risk positions that I've just described. What we will do is continue to work through our principles of risk management in terms of financial risk, looking at how that can be dealt with within individual organisations, then places, and then the system in terms of managing that financial risk between now and the end of the year. And we will, of course, continue to discuss this in more detail through the Finance, Investment and Performance Committee.
Thank you very much, Jonathan. For anyone watching the board meeting in person or live or on record, that financial information that Jonathan's just talked about is available in item 18 on the website, 18A, and you can see the breakdown there by place and by NHS provider in West Yorkshire in terms of month 7 financial reporting. And in our board meeting in private earlier, we did say that in between this board meeting and the next one in March, we would have a delegated group which we have used before for urgent decisions, to be available to support our financial oversight, which would include Chair, Chief Exec, Director of Finance, Audit Committee Chair and Finance Committee Chair, just to note that. Thank you, Lou. Thank you, Jonathan. I'm going to hand over now to Laura just to give an overview of the Corporate Risk Register. And then if there's any updates on committee reports, please let me know. Otherwise, we'll get straight into a discussion. Laura.
Thank you. And the report marks the end of our third risk cycle for the year. All the risks that are within the report have been reviewed by the Executive Management Team, and then they have been to either Finance, Investment and Performance Committee or Quality Committee. And the key feedback from the discussions in those committees is included within the report for your information. We currently have 54 risks on the register, of which 8 are new, and there are 4 that are marked for closure. The detail around those is set out within the report. Particularly draw your attention to the 8 new risks that are at paragraph 3.4, and particularly highlight one that's entered at a high level, 2456, which is in respect to the discharge of health protection statutory duties. Overall, we have 14 high-level risks, 5 at a critical level and 9 at a serious level. To draw your attention to 2232, which relates to infrastructure investment, as that has escalated from being a serious level risk to a critical level risk. The report also contains a number of horizon scanning risks, some of which we've talked about already as we've worked through the agenda. So the future role of ICBs, hybrid closed loops, the sustainability of the hospice sector, and shared care prescribing of amber drugs. The board's been asked to review the risk register, consider whether it is sufficiently assured, and consider whether there are any further emerging risks on the horizon. Thank you.
Thank you very much, Laura. That's really helpful. And then, as we know, we have got, which is available online, but also board members have it in their combined pack, AAA reports from the board's committees across our 5 places, then our West Yorkshire committees of Audit, Finance, Investment and Performance, Quality, Transformation, and then we also have from the Primary Care Team and the Dental Executive as well. I have a couple of questions, but I am going to hold those unless there is anyone around the table who would like to, first of all, update on the committee reports. Therese, and then I'm happy to then take questions so I can come to you. Ian, do you want to give an update on the committee question? Okay, so we'll hear from Therese, I assume, on Bradford District and Craven Place Committee AAA report, and then Carol from Kirklees, and then we'll get into general questions, for starting with Richard and Ian. So Therese, over to you. Would you introduce yourself?
Therese Patton, Place Lead for Bradford District and Craven Place. So just 2 things from our meeting on the 18th of November. The first is around a risk around the voluntary sector. We had a presentation from our voluntary sector lead, Sam Keithley, and our care provider lead, Louise Bestwick, who talked about the risk that the independent sector was facing, the voluntary sector and the independent sector was facing. We had a good conversation about that and felt it was significant, and it was something that we needed to keep an eye on in terms of our place, particularly as we go forward in planning. We are possibly unique in some of the work we do in our place, that a significant amount of our mental health spend, I think it's about 11 or 12%, is spent through voluntary sector organisations in terms of our provision. So we thought it was really important that we recognise it as a risk. And then some interesting and good news for us, we have a listen-in programme where we go out to our communities. We've been running this for a while. Our last programme looked at women's health, and as a result of what we've heard, we are having a women's health conference in association with our university, and that's going to be in February. And we're going to look specifically at women's health issues and matters, and we're looking forward to that, Chair.
Thank you very much. I wonder if Fatima Khanshah and the work she is doing with the West Yorkshire Women's Network might want to support that as well. Great, thank you. Carol, update from Kirklees. Would you introduce yourself?
Oh, hi, I'm Carol McKenna. I'm the place lead for Kirklees. It's not quite so much an update on the AAA report, but more just to support Laura's comment about the emerging risk on hospices. That hasn't featured in our local risk register that was received at the last committee, but we do now expect to put something in for our local situation in Kirklees, but also make the connection with Laura's team in terms of how that sits alongside any sort of corporate risk. So I did say I would flag that up, as the timing was just slightly delayed on the risk register.
Okay, thank you. And then that links with recommendations from public health colleagues earlier on commissioning with hospices, and we recognise their national lobbying and influencing work that they're doing at the moment for their to fund their work. Okay, thank you. So now we'll take comments from board members. We'll start with Richard and then go to Ian.
Thank you, Chair. This relates to the ambitions that we have, and particularly in number 1. You'll see on page 575 of the report and the supporting metrics. At the last meeting when we talked about health inequalities, I raised that the asthma guidance nationally was going to be updated, and that indeed has happened. And so we now have quite radically different encouragement to clinicians to prescribe combined inhalers. I think that will make a significant difference to the well-being of people and maintaining good health if we can encourage their use. So I just wonder whether the group looking at this when they next come to refresh might consider whether a focus on the type of inhaler, the prescribing of inhalers might be something that we consider, because actually the more that people use these inhalers, I think the better their health will be, will reduce risks of admissions and also improve people's health. Yeah.
Thank you very much. I don't know if James, you want to respond, or Ian with the Fuller Delivery Board, or Lou? Number of people, okay. Lou, thank you.
I must say that we've actually used some of the data in some reports for the Quality Committee, and I think it would be really good to pull that out and look at it and track this change and see what it means locally. So I think that's something we can look at and bring to a future meeting.
Thank you, James, and then we'll come over to you, Ian.
I suppose the other thing I'd suggest will be picked up, I think, with the long-term conditions with respiratory and with our medicines optimisation team in terms of how we promote and how we kind of support primary care with this as well. So and then making sure that obviously that's then picked up through the performance.
Thank you. Ian, over to you.
Yeah, thanks, Cathy. Ian Holmes, Director of Strategy and Partnerships and Deputy Chief Executive. Firstly, I think the additional analysis that we've got on the 10 ambitions is really helpful, and pulling out the metrics that are amenable to ICB action or intervention, I think really helps in terms of describing what we can do to push the dial on those metrics. I just wanted to come back to slide 59, the one that you emphasised, Lou, where there's a pretty stark figure in there, isn't there, where if you're a child from the most deprived quintile, you're 3 times more likely to be admitted to hospital with tooth decay than if you're from the least deprived, and that's nearly always preventable. And it looks like that's costing us nearly £8 million a year. There's work that we're doing through the Dental Investment Plan to address that. So, for example, we've put in place, I think, about £300,000 to work with practices in the most deprived areas to tackle inequalities in children's health. We've worked with local authorities to implement evidence-based toothbrushing schemes. But I think Rob made the point earlier about the relationship between financial balance and inequalities, and clearly there's some low-hanging fruit there we could potentially do more to tackle on together, particularly on dental, where we've got a little bit more room for manoeuvre than some other areas.
Thank you, Ian. That's a really helpful update. Bev, we're going to come to you, and I'd really welcome an update on our work with Yorkshire Ambulance Service as well, because that's obviously, it's coming in now and into the winter planning, but if you could include that in your response. Thank you.
Okay, thank you. Mine's in relation to the RSV vaccine for pregnant women, again with my local midwifery and neonatal system hat on. So this is in reference to the new risk at 2455. So we think that risk is mitigated. We have had we've rolled out the offer to all pregnant women. It has been challenging, but actually all provider organisations, maternity services offer the vaccine. We've given quite a lot. I think we've given 3,600 vaccines to date, or last Wednesday we'd given 3,600 vaccines of a potential 4,000 women, but that is just an average based on our West Yorkshire birth rate. We're doing some more detailed analysis of eligible women. We are seeing quite a bit of vaccine hesitancy. And there's lots of work that we're doing with the midwives that are delivering this. However, 70% of the vaccinations have been given in primary care. So we are there's some focused work around pregnant women, and we expect that the new risk 2455 will probably either be vastly reduced in the next risk cycle or even disappear. So in relation to Yorkshire Ambulance Service, okay. So the board and the general public watching will be aware of the focus on ambulance turnaround. So this is when ambulances are deployed to convey people to hospital. And also that the attention on ambulance delays last year and more so the previous year, given the risks that we had within the system. So I'm speaking as the chair of the Quality Oversight Group for Yorkshire Ambulance Service. And in that group, there's not only West Yorkshire ICB, but also representation from South Yorkshire ICB and Humber and North Yorkshire, because they all use Yorkshire Ambulance Service. So YAS have undertaken significant work to focus on patient safety. So this is not around a target, of which a CAT 2 response is 15 minutes. CAT 2, for people that are unaware, are people who have had heart attacks and strokes. So the national target is 15 minutes. There is very few areas in the country meeting that target. There's a detailed escalation plan has been developed by Yorkshire Ambulance Service that gives a number of actions to be undertaken in various scenarios, from business as usual to in extremis, so when we're at our greatest system pressure. And this includes something that's called a duty to rescue protocol. I think I've mentioned that previously. Most certainly we've talked about it in Quality Committee, but this was introduced last year. And that is deployed when ambulances are waiting to hand over patients in emergency departments, but there is a 999 call in community and a patient to be conveyed to hospital and who are at significant risks. So what the ambulance service do is work with clinicians within the emergency departments to say, I now need to hand over this patient because I've got to go and respond to another call. And then there's also work to improve on the ambulance handover times, with an ambition to come down to 45 minutes. And that is, and as I've said, that's for CAT 2 patients, so category 2 patients, strokes, and patients who are having heart attacks. There's also, we've spoken in, as I've said, in Quality Committee, but also at this board before, around the use of temporary escalation spaces, and we have mentioned that in the private board. So this is where we need to put patients in temporary escalation spaces until we can find them a base ward that's preferably the speciality in which they need to be cared for, and we've reinforced that NHS guidance that were published in September extends to ambulance patients in ambulances. So intentional rounding, ensuring that intentional rounding to ensure that they've got they're subject to the right comfort rounding, etc., but also that they've got clinical oversight from a lead doctor and also a senior nurse. And also last week there was another letter that came on the 12th of December to talk about a 15-minute handover for patients who were experiencing stroke or heart attack. So there's lots of national guidance. We're interpreting that into operational plans, and we are working with not just Yorkshire Ambulance Service, but provider organisations as systems to ensure that these plans are enacted. We had a regional meeting last Thursday evening with the chief medical officers, chief nursing officers and chief operating officers from all provider organisations and also ICBs, where the Yorkshire Ambulance Service chief paramedic presented all of these plans in detail, and I think they were really well received. Other people that were on the call and some are sat around this table might have other observations, but the conversations that I've had is they were really, really well received. There was also a presentation from another system about their urgent and emergency care response, really detailed, and it went into detail about quality assurance processes, expectations around organisations and assurances for ICBs, including what patients should expect. So we've talked about quality and safety, and this is about quality and safety of care in extremis. And myself, James, Lou and Anthony have had a number of exchanges. We're going to meet to look at what we can adopt in West Yorkshire, what we need to adopt in West Yorkshire in the absence of having a a team for this, because this other ICB had a big team that just focused on this, but we think that there's some really good work that we can adopt in West Yorkshire to get that oversight and assurance around quality and safety of care. I think I'm going to stop talking now, but I'm happy to answer any questions if people have got any.
Bev, that's really helpful, thank you. And as colleagues around the table know, we're the host for Yorkshire Ambulance Service, and that is really helpful. I know you're involved, Rob, they've invited you to be much more involved in that oversight, working across 3 systems, not only with our system and TEM providers, particularly acute providers, but across those 3 systems. So thank you. We also have an offer from Yorkshire Ambulance Services board members to go and visit their 111 centre. If anyone would like to come and join that, we're going to try and arrange that in the new year. We haven't been for a visit maybe for about 12 months or so. So if anyone would like to come and join me for a visit to the 111 centre in Wakefield, then please let me know. Okay, Bev, thank you so much. We've still got some other colleagues who want to comment. We've got Kim, then Fatima, and Jane. Thank you. Oh, and then Rob. Okay, so Kim.
Thank you. I just wanted to talk about the piece of work on the health inequalities data and the strategic ambitions. I think it's brilliant, and it's a shame that Sarah Smith isn't still here to have this conversation. It would be, what I'm interested in is, as you might expect from me, is that, okay, what next? What are we going to do with that information? Because we can look at those slides as a board and feel probably collectively horrified at some of the things that are on there. It would be, I love the fact that we will have show a clear intention by bringing this information to the board, so we're clearly cited on it. But in terms of how that plays into the next steps in terms of our strategy, our role as a strategic commissioner, about what we're going to do next in terms of the planning guidance, how will we bring this rich data that we have into the next stages of the process and keep an eye on it, so this isn't just a one-off, let's all have a look at how bad this is. And there's amazing work going on in West Yorkshire, but how do we hold ourselves accountable for setting some targets, really being clear on the evidence-based interventions and whether we are all truly adopting those at place. Thank you.
Kim, thank you very much. And I think on reflection, the strategic ambition should have sat with the board assurance framework when we discussed it earlier. The 2 things connect together, and then connecting with our update reports that come to the Integrated Care Partnership, the next one being in January, that talk about the progress reports. So I think it's a fair challenge. We don't have the planning guidance yet, but I think there's more we could do to finesse this. So Ian.
Do you want me to come in on I think it's exactly the right question. So I think the first thing I'd say is that the ambitions are owned by the relevant part of the system. So for example, if you look at the cancer ambition, that's owned by the Cancer Alliance, and they have this data and they're working with that data. The stuff around dental is known by the dental team and is informing their plans. So it's connected through to the way that the organisation works. I think it almost feels like you'd have a deep dive in every one of those ambitions, doesn't it, in terms of the focus on kind of conversations here. And I think by combining some of that data with the data from the board assurance framework, that should help inform our future plans going forward. Because I think some of them, particularly when you look at the improvement that we're making absolutely no difference in terms of deprivation or by ethnic group. I think that's worthy of further conversation here.
Okay, so we don't have the answer for you, Kim, today, but I think it's a fair challenge in taking that forward. And also how we bring together better the Integrated Care Partnership work and reporting with the Integrated Care Board. Okay.
Sorry, I think Tim might have wanted to come.
Tim, do you want to come in at that point? Thank you. Tim, would you introduce yourself?
Yeah, hi, Tim Riley, Place Lead for Leeds. I think there's a really important point, and it links to Ian's, that we're taking these back into conversations at Place as part of the planning, where we're prioritising in terms of transformation and change. And that often that is with the wider partnership. So I wouldn't want people to think because the board hasn't got a single plan that these things aren't being taken into account. And going forward, I've briefly touched on this conversation with Ian. I think there's something about, and it links to your point, Kim, about setting goals and targets. There's something about understanding where different places and different parts of our system are against some of these and where they need to put their emphasis. And almost as a board being assured that in Leeds we're emphasising the right things. because it's quite difficult to chase these 10 and about 50 other things that sit round the world at the moment in terms of healthcare. But I think that's where we perhaps need to get a bit sharper as a board. Are we sure that Leeds or Wakefield are focused on the right areas in their local planning?
Tim, that's really helpful for us to take forward into the new year. Thank you. We've then got Fatima, Jane and Rob. Fatima.
So this is what's really annoying about going after Kim Shuttler, because she literally said what I was going to say, and then Tim also said what I was going to say. But what I will add to that very insightful contribution to the board is, as well as place owning the areas of focus, that we also support each other. So if there is a place that is doing a really good job on an area that another place isn't doing so great on, how do we get that cross-pollination and do what ICSs do, especially us, do best, which is, showcasing that good practice and learning from each other. I have to say, Lou, I am so proud of the work that you and Sarah have done on the 10 system ambitions and the way in which you've taken quite limited data, really, and finessed it in an ability to explain to me, if I was watching this webcast right now, so what? If you're sat here right now trying to make a difference for me in the part of West Yorkshire that I'm living in, how do I know that you're making a difference to someone like me who's Asian, who's living in an area of deprivation? And I think we've started to address some of those questions. It also beautifully, and I don't know whether you did this on purpose, addressed some of the bits that Rob mentioned in his chief exec report about the CQC highlighting areas of challenge for people with learning disabilities and ethnicity, and then in the mental health section you've already highlighted those areas of data. So I don't know whether that was intentional, but if you didn't, well done, that was really nicely done. I suppose my question is, with the independent review that is taking place being led by the incredible Dame Donna Kinnair, one of the things that we really need to get better at is capturing data segmented by ethnicity. I suppose, is there an appetite and an opportunity for us, if we're truly wanting to do this properly, that we look at it through the lens of other protected characteristics as well, if we're truly going to hit the target and not miss the point, is my first reflection. My other one, and I know it's really obvious, but I think it's important that we say it for people watching and in the room, is just because we're hitting a trajectory or we're doing better than we've done before does not mean that we do not acknowledge what it feels like to be sat in A&E for more than 12 hours, or that you've been sat waiting for more than 55, 60 weeks for treatment and the impact that has on your lives. I think it's really important that we continue to say that, even if we think people know. And I wonder whether the work that we're doing in health and work, for example, can really support some of this. So I've seen, we've got areas of oversight and governance which are really important, but I think the work that Ian started to lead on with Jen will really help support people with the targeted interventions. So it isn't just that we're trying to hit everybody in the same way, but we're using the data in a much more impactful way, getting it to people who need it the most to help them live the fulfilling lives, because not everyone is in the same place. And then the other thing I would say as well is, are we being smart enough about the place-based focus in the context of what is right for Wakefield won't be right for Bradford in the context of ethnicity, for example, and can we reflect that in some way in the report? I'm sorry, Lou, every time I see this, I'm like, can we finesse it a bit more? But I just think it would be really helpful for me as the inclusivity champion, for example, to have assurance that we're hitting the trajectory in a way that is truly addressing inequality, but also highlighting the differences in the different boroughs. So we're really hitting that Sheila test of people in the grassroots of West Yorkshire.
Fatima, thank you very much. I'm going to leave you and Lou to have a discussion about that. Lou, do you want to briefly respond, and then I need to bring others in?
Firstly, I think we need to thank Jonathan Booker and Sarah Smith for the hard work on this, because they really are the champions of it. Look how far we've gone. These were a bit flat, weren't they? They're the right 10, but they weren't really working. So now they're getting dissected. We're getting really excited about, and we've just demonstrated how we can use the level of data. The AMR LAMP data we've got down to practice level. It goes out every 8 weeks, and there's a load of work that happens with the practices led by the primary care leads and their quality leads. The stuff happening under each of them, there's still more to do. So definitely. And in terms of ethnicity, that's exactly what we're looking at, to see how we can look at the data. And we looked at a spreadsheet, didn't we, Ian, about what was possible now. And we have got probably about 4 of these metrics already that we can look at it through that lens. So thank you. I'll pass that back to Jonathan and to Sarah. Thank you.
Thank you. Ian, briefly.
Yeah, it's a constantly evolving piece of work, and it will continue to get better. One thing that we should have included under Ambition 8, but we didn't, was if you look at a time series of board representation, of staff representation by a different group, there is significant improvements pretty much across every organisation in West Yorkshire, and that was demonstrated really clearly in the last review by Dame Donna Kinnair. So we have got a time series on that, and we'll include that next time because it's a really positive picture.
Great, thank you very much. We've got comments from Jane and then Rob. Just before we go to Jane, I wanted Sarah whether you might just respond, please, on a theme that's coming through a lot of committee reports and the risk around supporting our neurodivergent population in West Yorkshire about appropriate diagnosis and support. There's a number of challenges coming through at place level, a request from Calderdale on a system response to this, and a rethinking, which Robin we can very clearly see in your a report from Calderdale. So Sarah, I'll give you a few minutes, but if we could come back to you then on the work, and I know your colleague here is working on this at the moment, so it'd be helpful to have an update. Jane, to you, and then Rob.
Thanks, Cathy. So I was looking at the risk register report. Thank you, Laura. And I was really looking at the sort of place risk section of it. We've commented previously, I think, in terms of sort of the spread of risks and how they're reported across the different places. It's a shame Therese is not here for this part of the meeting, but I'd be really interested. We've talked about Bradford previously having a significant number of risks, but not only a significant number, but also quite a lot of quite significantly static risks. So, you know, Therese is relatively new into role, but I do wonder whether it might be time to have a bit of a deep dive through Audit Committee in terms of sort of what's going on, as much because we're not seeing the sort of movement on them, and thinking about some of the conversation this morning, you know, the tolerance around sort of having risks sitting there but not making an impact on them. I think it's really important that we remember this is the risk register is there to prompt action, response, mitigation, more so than just flagging and communicating. And you know, in a tighter environment, I think pressure is going to be on us to be resolving things more quickly, particularly on some of the financial stuff. And it'd be good to see that flowing into some changes within the risk. So I think it might be nice to do that at some point. Thanks.
Okay, so if we leave you to talk, as Audit Chair, talking to Therese Patton as Place Accountable Officer for Bradford District and Craven, and your point, Jane, in general, whichever place it was, you can see a place has static risks and we need to have oversight of that and better understanding. Tim, did you want to come in?
Yeah. Yes. So you'll see from the Leeds report, the AAA report, we did alert that we had a long conversation, both at our subcommittees and also at the committee, around how assured we were that the action taken to manage risk. And we actually said we're not that assured. Now, what we meant was not we weren't very focused on it, not that the actions were the wrong things to do and there were loads of things we were forgetting, but trying to balance financial performance generally, quality and safety, and inequality was an incredibly difficult circle to square. And therefore, whilst we were assured about the level of work being done, we were not entirely confident that that would deliver an improvement in the position. And I think that's part of what we're all dealing with at the moment, and was quite an important part of our conversation, certainly at the committee. It was this last month. Yeah, it might just be helpful to sort of talk through.
Thank you, Tim, for your openness. I'm going to go to Rob, who may want to respond to that comment. I know you want to come in, Rob, and commenting on the reports, and also wanted to pick up at Kirklees in their AAA report have talked about their accountable officer role, because, Carol, you will be retiring in a matter of months, so that was noted in the report as well. So I don't know if there's an update there as well. Thank you, Rob.
Yeah, very happy to do that. So I think to Tim's last point, we did have a good conversation, didn't we, at board development around risk tolerance and what we accept as risk now that we would probably have found more difficult to accept previously. We're living in a context where the national target this year for CAT2 response times on average is 30 minutes against a national standard of, 18, 19 minutes. So we know that that is not as safe as it should be. So we are accepting risk in a way which I think we want to move away from over time. We need to get to a less risky environment and less risky context. I just want to give some updates and then just, I think, an action that we'll need to agree. So on the risks that we've seen and discussed in this item and previously, on the voluntary sector and sustainability, we have had a discussion at the executive management team about NHS contracts, which are held by the third sector. As we go into uplifts for following years, they should be guided by whatever the uplift is in for NHS organisations. That's for the inflationary elements, not necessarily the volume, so we'd have to have a different conversation about that. But that was all part of recognising that the minority of voluntary sector income is from the NHS, but some of it is for NHS contracted services, and they should be treated fairly. Secondly, on hospices, we've been having good conversations through Places, as Carol says, with hospices and with the Hospice Collaborative, and we have had to have urgent conversations with some hospices to support them through some very difficult times and been offering real support, financial and practical. Third, on the closed loops emerging risk, we met as the executive management team and agreed an approach which will ensure that that risk is mitigated to a greater extent and that we continue to meet. Currently we're exceeding all of the national expectations on rollout, and we will meet all of the national expectations on rollout. And just on the ambulance service, we will have an extraordinary executive leadership board this Friday, which I will chair. That's what they've asked me to do in my role as our role as lead commissioner, to make sure that everybody is seized of the issues that Bev's described in what will be a difficult time for the urgent emergency care system through winter. Just thought those updates might be helpful. In terms of the ask, or actually the action from what we've been discussing, I think we've all described how the performance update and the risk register gives us a clear sense of where we might want to go on the national targets and the 10 big ambitions. And as we sign off the planning, as we sign off our plan for next year as a board, I think we need to receive information which allows us to do that, which picks up the points that have been made around the table about, are we clear that it does deliver the national targets and standards to the extent we can, and the financial targets and our approach on the 10 big ambitions, with an eye on the inequalities in the way that we've described earlier, with the priorities that we've got within that, and that we understand what the differential approaches will be in places. So Ian and Lou and Anthony, because of Anthony's review of the place arrangements, need to take that forward, I think, and devise a way in which the board can be assured when we sign the plans off, hopefully in March, rather than in June. Because I think we need to sign them off in March, given the financial outlook for next year. So I think that's the action.
And Kirklees?
Kirklees, yes, the irreplaceable Carol McKenna is retiring in March, and we've just put out an advert across West Yorkshire for a temporary replacement, a fixed term temporary replacement till October, to allow us to get through Anthony's review into place arrangements and to understand what the national arrangements are going to be following the review of the operating model, so we can then respond appropriately. So if anybody is interested, who's watching or sitting around the table, you don't have to be Carol, you can be yourself. You'll do it differently. But thanks to Carol for all the work that she's done. We will have other board meetings in which to celebrate her contribution.
Thank you, Rob. It's just particularly outlined in that report from Kirklees, and thank you, Carol. But we will celebrate you at the next board meeting. Embarrass you. I just want to come back. Sarah, I asked you, I know that you're our system lead for our mental health, learning disability and autism collaborative. There's a number, throughout the risk report and committee reports, there is a discussion and mention of supporting our neurodivergent population and concerns on demand and service provision. Would you provide an update? This particular ask from Calderdale about a new system approach. Would you respond?
Yeah, so firstly, the reason we held the neurodiversity summits in the first place is because all of our places and our providers and our population that we serve were identifying this as a significant issue, both in terms of access, experience and outcomes. So Calderdale, like all of the places, have been actively involved in that work and all of the key stakeholders. I would describe the progress that we're able to make is as marginal gains, so we can make progress in terms of we're looking at improving the consistency of the commissioning framework, improving consistency of clinical standards, assessment processes, trying to move to uniformity around the way that we respond to the right to choose national policy, and the quality assurance of those providers that engage in that. We gave an update to the System Oversight and Assurance Group just at the last meeting, which was a very honest, candid conversation along the lines of, even with all of this, the scale of the current demand, we don't have a plan that will meet everybody's needs and expectations, whether that's around access to diagnosis or post-diagnostic support, whether it's reasonable adjustments in people's employment, in their education setting and so on, because it also requires a multi-agency approach. So what we've been asked to do by the System Oversight and Assurance Group is to then do a further analysis around where are the biggest risks and issues within the totality of the population. And just as a reminder, we're talking about the discrete group of children with autism, children with ADHD, adults with autism, adults with ADHD. They are different population groups and different service offers available and different providers and partners and voluntary sector resources for each of those. So we're going to bring a paper back when that work is completed to System Oversight and Assurance Group and have a conversation as a West Yorkshire Health and Care system with the resources we've got and where we believe that we can make progress, where should we prioritise making that progress, recognising none of this will meet everybody's needs and expectations, but we can demonstrate we've been as thorough and assess the impact of that as we can. And there are lots of different innovations that places are doing and providers and partners. So we are exploring the use of technology and AI through streamlining the assessment process. There's work taking place of how do you get reasonable adjustments without a diagnosis in things like education settings. In Leeds, we're piloting a model with the GP Confederation around access to diagnosis and support in primary care. But again, even within all of that, the scale of the demand still outweighs where we're at in terms of resources.
Thank you for that update. And if we can continue to hear your progress with work and the strategic choices and hard choices that you're having to make. Robin.
Just coming on that, and thanks, Sarah, for the update. So I think there's really good work going on in West Yorkshire. The ask was less almost about the West Yorkshire response, but the ability for us to articulate this as a national challenge. And the current framing of the 10-year plan doesn't seem to make it easy to raise, which are one of the I think the top 2 or 3 grand challenges for the health and care system for the next decade. And it seems notably absent. And the 3 kind of prescriptive kind of models from the Secretary of State don't speak to it either. And I think we've been looking at the figures for home to school transport. We've got one young person that's costing £45,000 a year just to get to the place of education before the other costs. The trajectory is scary, and we don't have a national solution to that, or I don't think sufficient attention to it nationally, despite the fact that I was in a meeting with the Cabinet Secretary who said the one thing that local government faces is SEND. And I know there's other aspects of this issue. And it's in the OBR report that came out with the budget because of the scale of deficit that is being incurred by public services. And yet the attention to kind of a reform, public sector reform agenda isn't there. So it's almost our voice as being heard as possible that this is as big as actually hospital to community, I think, for the next decade for us and all our places. So so just building on that ability for us to have a voice and influence, really. Recognising that all the answers aren't in West Yorkshire on this. Sorry.
Thank you, Robin. And usually out of these meetings on our integrated care partnership, there are themes that come out, asks, concerns that we want to raise as a point of influence. regionally and nationally. My colleague sat to my left here is part of that 10-year planning, but I think there is something that we can do together through Change NHS in working and supporting Rob, as well as a system in talking to national decision makers and influencers. So let's leave that as an action and work through the appropriate channels we can use. Rob.
Yeah, I mean, I think we could commit as a board, couldn't we, to raising this formally, either on our own or with the other ICBs in Yorkshire and Humber and North East Yorkshire and Humber. It seems to me that what Robin's described is rightly, because really I think you the issues you highlight, Robin, are about children, but that's where it's felt acutely. And because I think the key thing out of the SOAG meeting was to say, let's segment this. You know, ASD is different from autism. Sorry, ASD is different from ADHD, and the response is different. Children are different from adults, and therefore we need to think about those differentially. So let's think about a sophisticated response that says this is about SEND, but it's about the other stuff too. And how do we respond to what seems to be, I think, in conversation with clinicians and others, a change in the environment and our communities amongst some adults to recognise they may have always lived with someone like they quite like something, they might quite like to understand what it is, whereas others quite happy just to cope. And how do we support people to cope without a diagnosis? I think we definitely need to respond to that because it is such a huge issue for everybody.
Thank you very much. We'll take that as an action and a considered way in which we do that piece of influencing and highlighting. Thank you. I think I'll call that to a conclusion then. Thank you, colleagues, so much for that discussion. I think in hindsight, we'll move the 10 ambitions into link with the BAF in future so that we can then focus on the here and now. Thanks to everyone who's put those reports together and taken questions, as well as for those of you who've looked at that detail. Before we take a break, I just wanted to move us on to the next item, which is around item 20, which is the provision of external audit services. Which Jane Madeley as Audit Chair and Jonathan as our Director of Finance have shared a document with us, and they are recommending to approve extending the current contract that we have with KPMG as our external auditors. I don't know if Jane, if you just want to add anything to that, any request to board today?
Not a lot to add, except to say, we had a full discussion in terms of the auditor panel, and we had several options presented to us. So obviously we've simplified it in terms of making the recommendation, but it was a full option analysis of routes to securing external audit provision. But we were, I think, unanimous in our recommendation that's come forward today in terms of reappointing KPMG.
Jonathan, is there anything to add?
Nothing to add from a Director of Finance perspective. The auditor panel's comprised the non-exec members as opposed to myself, so I was there to advise and support as opposed to be one of the decision makers.
Thank you. Board colleagues, are we happy to support that recommendation from the Audit Committee Chair? Yeah, okay. Thank you very much, and thank you, Jane, for that. Colleagues, we're going to take a break now for about 5 minutes or so. For anyone watching online, I really apologise that you've had intermittent coverage. It's due to the Wi-Fi in the building here in Leeds, but there will be a full recording of our meeting that you can watch back online if there is anything that you have missed. So we're going to take a 5-minute break, and then we'll come into part 3 of our board meeting today. Thank you.